Today we're going to be demonstrating how to pre-measure endotracheal tubes prior to intubation. This is something that you should do every time with every patient before performing your induction and intubation process. So I have my 3 different sized endotracheal tubes because I don't know what size my patient is going to require. This means that I do have to pre-measure each tube individually prior to inducing. When I'm going to pre-measure, I want to feel for the thoracic inlet. So I'm feeling for the point of the shoulder, and right there's my thoracic inlet. So similar to the groove where you're going to be holding off when you're doing a jugular venipuncture. You want to extend the patient's head a little bit, just so it's a little bit more straight. And this you can do when your patient's awake, or you can also do it once they're sedated, but you need to do it before you induce them. I'm going to start with my smallest tube, so I'm going to palpate the thoracic inlet, and I'm going to take the tip of my endotracheal tube that will be going into the patient, and I'm going to put that where the thoracic inlet is. Note that I'm not actually touching the endotracheal tube to the patient's fur because I don't want to contaminate the endotracheal tube because that will be going into their airway. So I can see that the end of the tip of the endotracheal tube, the patient end, where the Murphy eye is and the cuff, is going to the thoracic inlet. I'm then going to see where the end of the endotracheal tube, where it connects to the circuit, how far that goes to the end of the patient's nose. So what you ideally would like is this adapter to be just past the nose. So this is a little bit long, but not too bad. So I can see that if I intubate with this endotracheal tube, I'm going to have to ensure that I advance the tube all the way to have the 15 into the mouth, and this part of which would have been 16, this number 1, just past the nose. You don't want to be marking this with a piece of tape, because if the tape gets moist in the patient's mouth, it could come off and could potentially cause an airway obstruction once you extubate the patient. Some clinics will let you Sharpie it, but that obviously will be permanent. So ideally you can memorize this, or you can make a note of it on your anesthetic chart for each tube so you know how far to advance each endotracheal tube. So that's my first one. I'm now going to do my middle-sized tube, so my 4.5. And same thing, I'm going to palpate that thoracic inlet, and I'm going to then follow that and see where the endotracheal tube ends. So I can see that it's actually just at the end of the patient's nose. So I would have to advance this whole tube into the patient's mouth, and this circuit adapter would be just outside of the patient's mouth. So this one is almost perfect. Now my third tube is my number 5 diameter. So that's my largest tube that I've chosen. Again, palpating for that thoracic inlet, putting the endotracheal tube with a tip there and following it, trying to have the head in the natural shape that the tube is going to be going in when you intubate them, and making note of where it's going to be coming out on the patient. So for this one, really, this circuit here, the circuit adapter, should be way down here. So this endotracheal tube is actually way too long for our patient. What that means is it's a 5mm diameter, so this might be the perfect size endotracheal tube to safely fit in their airway. So the diameter might be okay, but the length is too long. So what we would have to do is once it's in the patient, because we want to make sure this is the right tube that we'll be using, we would then trim the endotracheal tube to the appropriate length, remove the adapter, and then push that back in so it's an appropriate length. A tube that is too long could give you increased dead space, as well as there's a higher chance that when you intubate it, that it gets advanced too far, which could cause damage, and you could also end up intubating down one bronchus instead of being in the main stem bronchus. Now for a tube that's too short, so this one was just about perfect. If it was any shorter, we would maybe have to consider having a different tube. So the same size diameter, so a 4.5 millimeter diameter, but one that's a little bit longer. A tube that's too short risks the chance of being dislodged and coming out, which once that cuff is inflated, that could cause damage to the tissues, swelling, increased chances of laryngospasm, and then the danger of having an extubated patient under anesthesia, as well as if it's too short, sometimes what will happen is the tube can move in and out a little bit more because the anesthetist might feel like they have to move it because it's too short, and that again can cause airway irritation and an increased chance of laryngospasm. So it is really important to ensure that you have not only the appropriate diameter, but the appropriate length. So really important that you pre-measure before you do your induction and intubation process.